Good morning, everyone. For those of you I don't know, I'm Bob Challoner. I'm the President and CEO of Southampton Hospital, and I'd like to thank you all for being here at this morning's presentation. And before I introduce our speaker, just a couple of quick words about our Tick-Borne Disease Resource Center here at Southampton Hospital. This was a project that was started in response to community and provider needs. We began probably about 4 years ago with a mission to do three things. Number one, because we are in an epicenter of tick-borne diseases out here on the east end of Long Island, we hear frequently from our patients and community members about their fears and lots of bad information floating around there, quite frankly, about tick-borne diseases. So with any sort of public health issue, the best way to fight it is with good information. So part of our mission, number one, is to get good information out to the public and the communities that we serve. And for the last several years, we've been engaged in a very, very active education campaign. And we have a number of things we've been doing probably this year, probably a couple of dozen community education activities at libraries, at schools, at social centers, and a variety of settings, including Bay Street. Every year we do essentially a sellout crowd in the middle of the summer with people coming to hear about ticks and tick-borne diseases. And every one of these sessions is packed with people, and we hope we are providing them with good information. We have a program we've developed for children. We have a school teacher who's here with us today, April, where I saw her somewhere, there she is right here. School teacher has developed a curriculum and has been out at the Children's Museum, schools, and a lot of different settings, teaching kids to be tick smart, and that's been a very, very valuable program. We thank April for doing that for us. So education for the public, education for you, the providers, and we heard from many different doctors, nurses, people really at the front line of treating tick-borne diseases that you would like more and better information, frankly, about what's happening out there. So several times a year we organize sessions like this morning where we bring in experts from the region and from really throughout the Northeast to bring you the latest and greatest information on diagnosing tick-borne diseases, information about ticks, how the diseases are spread, what are the various diseases, and some of the research that's being done as well. And we want to do this provider only so that you feel free to ask any questions. We figure the better armed you are with good information, the better we can fight these diseases in our communities. So this is for you today. Third area that we're focused on is navigation. We receive many phone calls from people and people showing up in our offices, in our emergency room, frankly frightened. They've been bitten by a tick, they have a tick on them, their children have been bitten by ticks, and they don't know what to do about it. And so we've created a hotline, 631-726-TICK. Rebecca Young, who's sitting in the back, is the tick lady, the voice of the ticks on that telephone, and she's receiving lots and lots of phone calls. Primarily in the summer, but throughout the year. We receive calls actually from around the country and a couple from around the world, actually, people looking for information. And her job is to connect people with the right resources. We purposely made a decision not to create a tick clinic because we would prefer to utilize the providers in the community out here, all of you. And the better armed you are with information, you'll be out there in the community. So one of the things Rebecca's always doing is looking for providers who are willing to see the patients, so please let her know if you have capacity in your offices, because she is constantly looking for places to refer these patients to, and if you have any particular interests as well. We've also begun some research, or supporting research. We're not doing the research, but supporting some of the research efforts underway. Some of the experts that we've been working with at Stony Brook, at UMDNJ, Rockefeller, are doing some research around things like development of better tests, development of immunizations, and because we see so many patients out here, have the opportunity to provide research material, i.e. patients, and we do have a couple efforts underway to help gather samples for some of these studies that are underway as well, and we can get you that information too if you'd like to participate, because the researchers are eager to get access to blood samples and skin samples. So that's what we're about as a tick center, and today I'd like to introduce Dr. Philip Molloy. He's the medical director of IMUGEN Medical Laboratory. Dr. Molloy has traveled to us today from Norwood, Massachusetts to lecture on ordering and interpreting blood tests for tick-borne diseases, a topic which can be extremely confusing for physicians as well as all medical professionals. We're very pleased that he's agreed to make a second trip to Southampton this year to talk to us. And by way of background, Dr. Molloy received his undergraduate degree from Bowdoin College in Maine, magna cum laude. He received his MD degree from Tufts University School of Medicine in 1981 and completed a residency in internal medicine at the University of Minnesota from 1981 to 1984. This was followed by a rheumatology clinical immunology fellowship at Tufts from 1984 to 1986. He's been a practicing rheumatologist in Plymouth, Mass. for the past 30 years. We're not holding against him the fact that he is a Red Sox fan, we learned last night. And he became the medical director of IMUGEN Diagnostic Reference Laboratory in Norwood, Mass. in 1998, a position he continues to hold. Since 2013, he's been a consultant on the medical affairs team at Crescendo Biosciences. Dr. Molloy's research interests include treatments and monitoring disease activity, outcomes in rheumatoid arthritis, clinical trials for therapeutic interventions for osteoporosis, rheumatoid arthritis, and osteoarthritis, and tick-borne diseases. Dr. Molloy has participated in numerous research protocols on Lyme disease and associated tick-borne infections, including the treatment of Lyme arthritis, and the development of laboratory tests to distinguish Lyme disease from the Lyme vaccine serological response, blood tests for screening blood donors for Babesia, and characterizing and diagnosing Borrelia miyamotoi. Not bad for a layman, right? Welcome, Dr. Molloy. Please give a round of applause.
Thank you. Hope I can live up to everything. So I don't have to spend too much time, I don't think, introducing myself after that. Thank you again, Bob. But I am a practicing physician when I'm not in the lab. I spent half my life in the lab, and I've been involved pretty much since the beginning of my career. I've had one foot in the lab doing test development and interacting with the clinicians that call. What does this test mean? What test should I order? There's too many choices on this menu. Which one for my patient would help me answer my questions the most? That's what I do in the lab, in addition to developing some of these tests. So you know now what the objectives are today, since that's been up there. I'm going to start with, first of all, I'm going to talk to you more about laboratory testing than clinical treatment. Not a lot has changed in the past 10 years on how you treat Lyme disease and other tick-transmitted diseases. Really not a lot has changed. The IDSA, the Infectious Disease Society of America, published guidelines now 10 years ago in 2006. I have a reference slide. In fact, the previous slide at the bottom, and Karen will have all these slides. Those are the slides that have references on them. Most of them are online links to references. One of them will be the treatment of tick-borne diseases by the IDSA. All the permutations and things you can't remember. Somebody has Bell's palsy, somebody has this, that, do they need IV, 2 weeks, 3 weeks, allergic to doxy, what's the next choice? They're pregnant, they're nursing, what antibiotics? All those things that are on these tables there for all the tick-borne diseases. And that's from 2006. The committee, the IDSA's committee, revisited them a couple of years ago and decided no update was needed. There had been no information of substance that would change any of their 2006 recommendations. So it's still the most current version. And IDSA is a free website. You go on there. On the right-hand side, clinical guidelines. diagnosing and treating tick-borne diseases, boom, download it, save it to your laptop, open it in a patient's room. That's what I do. So let's start with a couple of clinical questions, though. And this is a real question that was asked to me when PCRs became popular. And I'm going to make sure everyone understands the difference between serology and PCR within the next 5 minutes. So doctors sometimes, this urgent care ERs would just check everything under Lyme because they didn't understand what test to order, what panel, what group, what reflex, so they just checked everything. So I had a doctor call me and said, this was like 3 or 4 years ago, saying the Lyme PCR came back positive, but the serologies, IgM, everything was all negative. I think the PCR is probably a false positive in this patient. Is that true or false? One of them's false positive, or is that even true? Anybody have a comment? You'll see in a minute what the answer is. But there's a biologic reason for a discordance between serology and PCR, which will become evident in the next 5 minutes. And this is something that you guys live with all the time, is that after treating a patient for Lyme disease, you should do a follow-up serology. But then what if it's still positive and patients' portals, they go on the internet, they get copies of their test results. I'm still positive. All the patient, uneducated, less sophisticated patients, my test is still positive, that's all they hear. And that creates, you know what happens all the time. It's funny for me, by the way, to come to this epicenter and talk about it, but the only justification I have is the number of years I've been in this field and the fact that I have a clinic which is maybe even more ground zero than the East End. I have a clinic, I see patients on Nantucket, at Nantucket Cottage Hospital, which has the highest incidence of ticks and deer per acre and Babesia and Lyme than any other zip code on the planet right now. So I see a lot of it there, even though what I do there is mostly rheumatology. I do a lot of tick-borne stuff as well. So this is what we're talking about. Which one, I mean, this is for really neophytes. Which one is different? Which one of these pathogens? You know, I could step back and say this is not an exhaustive list of pathogens. We know that the Powassan virus and the deer tick virus are out there. They're transmitted by ixodes as well. We know there are other pathogens in various species of ticks out there. So these are the top 5, but it's not an exclusive list. So which pathogen up here is different from the others? Well, there's really 2 answers. The first is that HME is not transmitted by the deer tick. All the others are transmitted by the deer tick. So HME only exists in the United States in areas where the Lone Star tick amblyoma is present. It's very relevant for us, by the way, in north of here, in New England states, because amblyoma up until a few years ago never had been found in Massachusetts. And now there's occasional amblyoma sightings out there. But we don't have HME, 0 cases in Massachusetts. We did 10,000 blood tests, PCR, including PCR, for HME this past summer and came up with how many positives? 0. Cape Cod, Nantucket, those places. So we don't have it in Massachusetts. Ask me again in 5 years, this story might be different. What other pathogen is distinct and different on this list? Well, this is now biology. Babesia is not a bacteria, of course. The others are. Babesia is an intra-erythrocytic parasite. So that makes it different too, in a way. Here's my disclosure. I work for the lab that does your reference testing for tick-borne diseases. That's where we are, outside of Boston. People know that. I like this map. I'm going to show you 3 slides really quick right in a row, okay? 5 years later, 5 more years later. 2 things happen here. First of all, there's where you are, right there. And so you have a justification to call yourself the epicenter. That's where Nantucket is. Those are the 2 islands, Martha's Vineyard and Nantucket. But 2 things have happened. The epicenters are getting darker in that dark blue. So the density, the number of diseases in each of our towns right now is increasing. And geographically, it's spreading. So look what happens look at northern New England, which is New Hampshire, southern New Hampshire, southern Vermont, Maine, which were not endemic states 15 years ago, and look now. So that's what's happened. And look at the upper Midwest, where HGA was first described, by the way. by Dr. Johann Bakken, an infectious disease doctor in Duluth, right there, where was northern Wisconsin, in Lake Superior. This says it the same way, it's the same data. These are towns that reached maximum penetration of tick-borne diseases per 100,000 patients and all that per year. It's showing how it's spread out. The other tick-borne diseases, you know this graph. This graph happens to be Lyme, but it could be Babesia as well. I just would like to warn you that all of the pathogens that are on that first slide do not have the exact same curve. HGA peaks early, miyamotoi and Babesia peak later. There are differences. Larval ticks can transmit, it appears, HGA, but not some of the other diseases. There is a fall peak for Lyme because of adult ticks that is not present for miyamotoi, for example. So there are minor differences. But this is really the data for Lyme right now, nationwide. It's our data too. So this is an important slide in the next few. I don't want to be too elementary or insult anyone by being so basic, especially ID people here. I'm sorry if this is too elementary. Historically, forever, there have been two ways to diagnose infectious diseases. Number one, demonstrate the presence of the germ there. Demonstrate the pathogen. How do you do that historically? We cultured, right? We did immunostaining, special stains, syphilis, silver stains. We did sputum stains. We did urine cultures, blood cultures. We looked for the organism, TB. What's the second way you diagnose all infectious diseases? You look indirectly at the host immune response. TB, it's a skin test or nowadays a blood test, right? Or it's serologies. It's acute and convalescent serologies. So the laboratory, we culture, our lab cultures, but there are some diseases where culture is tedious, less available, or it just doesn't help you as a clinician. Does it help you to wait a month to get a culture report back for some TB and fungal and opportunistic things? No. It doesn't help you with a patient that's sick that's in your room tomorrow. It doesn't help you. Does a test that could demonstrate there today, would that help you? Yes. How about acute and convalescent serologies? There's many, many infectious diseases still today that we diagnose by acute and convalescent serologies. So, yeah, I'm a doctor now. I know what my patient had now that he's better. But it doesn't help me the day he's sick to have that as the only avenue of diagnosis. So which is why PCR has been so important at directly demonstrating the presence of the organism. And PCR does go back 20 years. There's been enormous technical advances over the past several years for PCR. Real-time is one. You don't have to know. If you want to know, I'll talk to you later afterwards what real-time really means, how it's done, all that stuff. DNA is extracted from a specimen. Could be synovial fluid or synovial tissue or a skin biopsy or a spleen in a Babesia patient or whatever. Could be a frozen surgical specimen if it's not in formalin. And you can extract all the DNA and then use very species-specific probes and primers and look for what you're looking for. Probes and primers are keys that can only open one lock in the whole universe. They're matched DNA sequences, 100, 200 base pairs. They're very specific, species-specific, not shared by DNA libraries, not shared by any other species. You just look, they go around the specimen looking for something to stick to. And then you amplify that. I would recommend you think of PCR as a molecular culture. It's exactly what it is. With in the best of all possible worlds, a 4 or 5 hour turnaround time. That's how long it takes us to do the test. The problem, especially here, and all the delays have to do with getting the sample to our lab. Once we get it, we know we have the answer by mid-afternoon, once we get it, of the day we start the test. Now, what's different about Lyme disease? I know you know this. We knew Lyme arthritis existed for a long time before the first spirochete was ever found in joint fluid. or synovial tissue. Same for cardiac. It takes a pathologist all day to find one spirochete. In Lyme disease, the paradox of Lyme, this is not staph infection, this is not pus. There's a scant number of organisms. So few, it takes a pathologist hours and hours and hours to find one or two organisms. So there's a very scant number of organisms that elicit a rather remarkable inflammatory response in patients, especially in the case of Lyme arthritis. Massive numbers of white cells, massive knees, and neurologic tissues. Sick patients, hardly any organisms there. Hard to see, hard to culture, easy to see by PCR. So Lyme have very good serologies, and they also have PCR available to you in certain circumstances. So this is a made-up slide. This is a slide to make a point to you, and I'm going to expand it in a second. For every infection, if somebody knows an exception, tell me, but I think this is true. You get infected by a pathogen, a germ, a virus, a parasite, TB. The germ is on board, you're sick, the germ is there, variable clinical manifestations, and then you develop an immune response. This is the sequence of what happens to us with all infections. We get the germ, we get sick, eventually we get cellular or humoral immune response, depending on a lot of characteristics, intracellular, extracellular. Fungal TB is, we don't have reliable serologic tests. We do have great T-cell cellular immune tests for TB. For Lyme, for parvovirus, this is true for hepatitis. This is true for every infection I know about. So let's move ahead a little bit. You're thinking, I have a patient in the middle of the summer on the East End who's been camping on Shelter Island. And now they're in my office a week later with a fever, a headache, they look sick, it looks like something's wrong with them. What's their diagnosis? Well, I don't know what their diagnosis is because a lot of these diseases look the same. Their phenotype is you just look sick and have a fever and a headache. But I do know that on that day, with 1, 2, 3 days of symptoms, I'm looking for the organism. A week later, 2 weeks later, I'm looking for antibodies. If you remember nothing else, that's what I'm trying to teach you today. Because you're going to see, depending on your computer, your EMR, your test ordering, your test menu, under Lyme, under Babesia, under Anaplasma, you're going to see a lot of boxes that you might think about checking. This is the take-home message. Early in disease, think PCR. I want to look for the organism. As time passes, the yield for antibody testing gets better and better and better as time passes. That will help you order tests. The other message is people get co-infected, which is why there are panels of acute tick-borne disease testings out there. And I'll explain that again in a minute. We call that the window period. That's a term borrowed from the blood bank community. That's the time it started in HIV, where patients are HIV positive, they're viremic with HIV, a couple of weeks, 2-3 weeks before antibodies. So if I get HIV, I could feel okay, become a blood donor 2 or 3 weeks prior to antibody testing. That leaves a little window, doesn't it, of vulnerability for the blood safety. That's called a window period. And that emphasizes, yes, the germ can be present before antibodies are. Does that mean antibody testing is lousy? Oh, antibody testing is silly, it's wasteful, no. It's biology of infections, isn't it? This is biology. It takes you a little bit of time to make an immune response that's detectable, that's measurable. And the germ is there first. So that was a cartoon. This is another cartoon. And this emphasizes that some pathogens, you can think of some pathogens have a very brief window of bacteremia or viremia or parasitemia. They're not around for long. They're not traditionally bloodborne. I'll give you some examples of this. Borrelia miyamotoi. is in your blood 4 days, no more than a week. Then it's gone. How about Lyme? Lyme is blood-borne. Gary Wormser showed that with culture stuff he's published over the past 10 years. What's the problem with culturing Lyme? Very few numbers of spirochetes. You need 20 ml of blood usually. You need a big volume of blood. It takes a week or two to see it. So is it useful clinically? Not the most useful thing clinically. But what has it taught us? It's taught us that most patients early in Lyme have a brief window, a low level of spirochetemia. How else does it get to the joint? How does it get to the CNS? How do you get multiple EM lesions? You have briefly bacteremic, low levels. Not like staph sepsis, where there's 1 million organisms per ml. This is more like 10, 20, 100 organisms per ml. Hard to find. So this could be Lyme. There's an overlap. Now this is all variable. So the good news is the principle holds water, and the principle you can take to the bank. The germ is there, then you develop a measurable immune response. That's the good news. Believe it. The bad news is that every germ has a slightly different picture attached to it. Some germs are not that longly present in your bloodstream, in which case you hope you've developed an immune response really quick. Are there, by the way, who hasn't read about Zika virus lately? So you travel. I have a pregnant daughter who was on her way to her honeymoon to someplace down south and canceled it because she's pregnant now and they were trying to get pregnant, and I'm not going to anywhere with a Zika, she said. And I don't blame her, by the way. Should I make another slide where the viremia is gone? There's a window where no test is positive before the antibodies, and yes, that's true for Zika. Zika is well worked out. I don't have a slide for this. You get bit by a mosquito. You're inoculated. 1 week later, you get symptoms. You're viremic for 1 week, then it's gone. Huge levels of viremia. That's why if a mosquito bites you during that week, it's getting infected and perpetuating it in your community. Unless you kill it right away. Kill it. And then 1 week later, you develop your first IgM response. So there's a week in the middle where PCR is negative and IgM serologies are negative. That's well worked out for Zika. Thank God there is another test for Zika for that week in a urine antigen test that week. So it's well worked out for most of these pathogens, how long you're viremic, how long you're parasitemic. And it's true for the tick-borne diseases. So the next slide, this is what Babesia might look like. Babesia is in your bloodstream. So Babesia is a gift to you guys, to us. Babesia is a blood-borne disease. There can be 100,000, 1 million, 10 million parasites per ml. It lives in erythrocytes, that's its home. Unlike B-Burgdorferi or miyamotoi, those are not blood-borne diseases. Different germs are trophic for different tissues in our body, right? Strep goes to your throat and whatever. This is like malaria, Babesia. So you have parasitemia that waxes and wanes for months, 6 months sometimes, treated or untreated sometimes. Of course, treatment shortens this. So very frequently, by the time someone sees you in Babesia, they've been sick for a while or parasitemic for a while. So most Babesia patients, it's like 80–85% that you see will have been percolating with parasitemia for long enough so that they will be seropositive at that time. So antibodies are useful for Babesia. They're useless for HGA and miyamotoi. Useless. No acutely sick, febrile headache patient with miyamotoi or HGA has antibodies. By that I mean 10%. They're all PCR positive, they're sick, they all seroconvert. At the time of the first doctor's visit, 90% are seronegative. Don't go to serologies then. That's my advice. So is there a window where both are negative? I don't know. For Zika there is. So let's talk about Lyme. So this is not going to be about treatment because you can look at CID. So as you know, anybody who uses this hospital gets a report that says Antibody-Capture EIA. That's an immunoassay, enzyme-based immunoassay. It's a version. Capture EIA is a version of an ELISA test, so it is a type of ELISA test, and it's designed and optimized to identify the first round of antibodies, especially IgM. In the lab, we have the choice to put our cutoff really low, in which case we pick up every possible early IgM, or we can make the cutoff a lot higher. What's the argument of making a low cutoff? We don't miss any early cases. What's the price you pay? It's going to be some cross-reactive stuff that's not Lyme that you pick up sometimes. So if you want to get rid of all the cross-reactives and say, I'm not going to call it a positive till the cutoff's up here, you might miss some early disease. So that's an inherent tension to all methodologies in the lab. A Western blot, you know how you do Western blots. I'll show you some pictures for anybody who doesn't know what a Western blot is. You take a culture of the organism. We're talking about B. burgdorferi. We do Western blots for Babesia too. You can do it for other pathogens. You take a culture, you chop it up in a blender, you dissolve it. That's crude, that's not really what's done, but you chop it up into all of its immunogenic epitopes, lipoproteins, outer surface proteins, and intracellular stuff that you can make antibodies. You put it on a nitrocellular strip, a gel, then you transfer that to a piece of paper. You put the patient's serum on that. If they have antibodies against those, it ends up looking like a barcode. It's very specific. So it adds a lot of specificity and ability to what I call staging. So Western blotting in general, by the methodology itself, inherently identifies antibodies of higher affinity and avidity. So it takes even longer to develop a positive IgG Western blot. So you don't develop a positive IgG Western blot until weeks into your infection. Weeks. Which is the underbelly of the CDC criteria, of course. Because to meet the CDC definition, a positive ELISA test or Capture EIA or any enzyme-based test has to be confirmed with a Western blot, which takes, let's say, 6 weeks. So anybody with EM and Bell's palsy and high titers on the ELISA doesn't have Lyme if their Western blot is negative, and they're all negative at that stage, early stage of the disease. So that's a known, well-known issue. The CDC criteria performs better and better and better the later into the infection you are, and falls apart in early infection. People are sick, culture positive Lyme, sick, meningitis, PCR positive in the spinal fluid. They're negative IgG Western blots at that stage, and they don't meet CDC criteria. It's a flaw. The CDC criteria is 30 years old almost now, though. But I'll show you some pictures of this stuff. So what's new? The newest thing, I think, over the past few years for Lyme is that PCR has become better and better and better, can identify lower and lower and lower numbers of organisms per ml in acutely sick patients. So I'm going to show you this slide. I showed it here last time I was here a couple of years ago. I forget when I was here. This is very educational, this slide. This is the average serologic response of 10 patients. Each patient had a documented tick bite followed by erythema migrans diagnosed by a highly experienced physician in a very endemic area. Diagnosed by Dr. Steer, definite EM. None of these patients were treated. They all went on to get Lyme meningitis, proven by spinal tap. They still were not treated, and they all went on to get Lyme arthritis. This is their immune response. How could that be? How could that be ethical? Who's going to do that experiment? This was 1977. The Borrelia burgdorferi was not discovered until 1981. The first blood test, first antibiotic trial was in 1982. Nobody knew what it was in the late 70s. So this is before the Lyme mystery started to be solved. What can you tell about, what can you learn, what can we learn as practicing doctors from this graph? First of all, if PCR was available in those days, which it wasn't, and we have no specimens on these patients now 40 years almost later, the first cases of Lyme were 40 years ago this year. And all the credit goes to persistent parents, because there was an outbreak in a couple of towns on the Connecticut River of JRA. Kids 4 or 5 years old with big swollen knees. Some of them had 2 swollen knees. The parents got together. The doctors wouldn't listen to them. The parents all knew that their friends' kids were having the same thing happen. They didn't take no for an answer. Yeah, you have JRA. And the parents said, how could we have 20 cases of JRA in one town all this spring? And they petitioned the State Department of Public Health to investigate it. And the State Department of Public Health, if you don't know the story, contacted Yale. Yale sent their youngest faculty member, Dr. Alan Steer, out to investigate. That's how it happened. So if PCR was available, it would have been positive there. Here's the other thing that's very useful. Patients with Lyme arthritis have been infected on an average of a year. I don't think it can happen earlier than 4 months, 5 months. It's a late manifestation of Lyme disease. The latest encephalopathy and Lyme arthritis are the latest manifestations of Lyme. By the time you get Lyme arthritis, a swollen joint, you've been infected with a highly immunogenic pathogen for a long time. You are always seropositive when you have Lyme arthritis. All right, I'm going to rephrase this. You go to your work this afternoon. You see a patient with a swollen joint. You send off a Lyme test, it comes back negative. You have ruled out Lyme arthritis 100%. Not 99.9, 100%. I'll say it one more different way. There's never been a case of documented Lyme arthritis that's been seronegative, and not just an IgM of 1.5. Floridly, robustly seropositive. That is useful information. So you send a Lyme test on your next swollen joint, and the IgM comes back at 1, right at the cutoff, and everything else is negative. You have ruled out Lyme arthritis in that patient. The other thing is that IgM persists, now over a year. So is this like parvovirus? No. Or hepatitis? No. This is not a simple viral infection. This is more like toxo or syphilis, isn't it? The syphilis blood test is IgM based. It's positive decades later, right? So this is IgM can persist. That is useful information. You treat a patient this year for early Lyme disease. Their IgM is positive next year when they go to some clinic and demand another Lyme test for whatever. And the IgM is still positive. Does that prove they've been reinfected, or could it be residual IgM? It can be residual IgM a year, 2, 3 years later. That is useful information. Need to know this stuff, really. So these are 6 sequential Western blots of one of those patients, showing you when I say we can sort of stage how long you've been infected by the Western blot, and this is what it means to be a barcode. So this is one patient having 6 different Western blots, all run the same test run over a period of time. These are, by the way, Elaine, these are 40 consecutive PCR positive Lyme arthritis patients, their Western blots in the serum, to show you that they're not just a little positive, they're not just one band, they're really robustly seropositive. When you count the bands, we count everything we see. I mean, some of these people have 20, 30 bands, really. They're not just barely positive. The only reason I put this up is I get calls, and you probably do too. I have a patient who had 5 bands, here are their molecular weights, and it was sent to Quest or LabCorp, and now they're at Stony Brook, or now they come to IMUGEN, and they have different bands. Does this mean the patient has been re-exposed, reinfected? So this is one serum sample, the same blood draw on a patient run on 2 different strains of B. burgdorferi. So you cannot take 2 different labs and compare their Western blots, because they're done differently, they use different strains, their passage different, and there are different upregulations and downregulations. It's fraught with errors. I discourage that. So I know there's a lot of labs out there, and people will come to you that they bring in labs from other places, New Jersey, Massachusetts, done differently. So I discourage you from putting them side by side and trying to make comparisons, because this is the same blood draw on a patient. So the next 2 slides are 2 patients. These are actually from Plymouth, Massachusetts, where I lived for 25 years. So this is my neighbor, if you're my neighbor, don't get Lyme because I'm going to come over and bleed you every Sunday morning. I'll bring the newspaper and coffee and return. And that's what actually, that's what happened here. So this guy got sick, and his IgA went away. IgA 98, 99% of the time goes away with resolution. IgA does what IgM ought to do, goes away. So what isotype persisted the longest in this guy? His IgM. Persisted the longest. So here's another patient on the same street, by the way. And he, 4 or 5 years later, this was 09 obviously, 4 or 5 years later, still had low levels of IgM. I have another one, but I didn't make a graph. IgA goes up and down, gone. So this guy had multiple EM, was symptomatic for like 5 days, kept telling his wife, if I'm still sick tomorrow, my wife said, go to the doctors. June, right? In the woods, in Cape Cod. Go to the doctors. If I'm still sick tomorrow, I'll go. If I'm still sick tomorrow, I'll go. First time he missed work ever. Finally, he had like 10 EM rashes one morning. And after like 4 or 5 days of headache and fever. And so this is 4 or 5 days into his first symptom. IgA is still going up. He started antibiotics that day, and then it goes down. So IgA going up. What if I did a blood test there, and I did a blood test 10 days later? I might make the erroneous conclusion that my treatment wasn't working. When this is just a natural history of antibody response, it goes up before it goes down. If you catch it on the way up and draw a convalescent or short-term convalescent test too soon, you'll catch it on the way up before it starts going down. Which is why we have multiple curves like this on a lot of patients in the lab.
Can I ask a question?
Yes?
Are these graphs not showing treatment at all?
They're all treated in the first day. Yeah. Nowadays, we don't withhold treatment when somebody has EM and stuff like that. So these are all treated patients. Good question, though. So IgM persists. So here's the commonest dilemma before I move on. Here's the commonest dilemma. The low IgM. You order a test, you didn't want to order it maybe. That happens, and then the IgM comes back low. What is it? What are the possibilities? It could be left over from last year's infection or 10 years ago infection, or it could be on the way up for a new infection. Oh my God, how am I going to tell? I don't want to get sued. I don't want to miss a case of early Lyme disease. How do I sort this out? Well, first of all, that's what it could be. What you care about is a recent infection. That's the one you don't want to miss. Is it on the way up? How can you resolve it? Well, IgM Western blots won't help. It's a poorly performing test. It's easy to do technically. Its inherent positive and negative predictive value is poor. It's negative in most patients who have biopsy-proven Lyme culture positives, EM lesions. And as false positives in nursing home residents in Arizona. I have 2 bands. That's a positive IgM Western blot. So it's not a great test. We do it. We have clients that insist it and hospitals that want it, and we'll do it, but I won't discuss the results because it's like flipping a coin. If the true recent exposure, the titer rises quick in Lyme. So do a test 1 to 2 weeks later. This is what it looks like. It's 10-fold higher usually. If you wait, depending if you wait 5 days. I mean, there are researchers in my lab who believe that 3 days is enough time to wait. You want to be really conservative, wait a week or 10 days. But if it's still 1 a week later, it's not recent Lyme. And if you wait another week, the IgG will be turning positive. And if you wait another month, the IgG Western blot will be turning positive. So an early convalescent usually always answers the question that you want to know. Is this patient recently infected? Treated or untreated? Now, this is an example of off scale. Look at these antibody titers here. Look at the IgG Western blot. Look at the IgM Western blot. This patient had physician-diagnosed multiple EM lesions and was febrile and looked sick, looked toxic, multiple EM. This is a patient from Connecticut, the coastal Connecticut on the other side of the Sound from here. Intensely seropositive. I don't know why you needed. I have enough information on this test not to need an IgM Western blot, but this doctor asked for an IgM Western blot and it was negative. I said, well, what are you going to do now? Not treat him? Multiple EM. I mean, you don't even need a blood test on this patient. Take-home message is that you need to understand a little bit about the serologies. Early in disease, you can find it by PCR. Later in disease, serologies are really helpful, and there's an orderly sequence. If you want these too, get them from Karen. You can have the whole thing. You can have them all. Window period. So here's a case. Here's a case from Eastern Long Island. I have some really interesting cases from the East End here, but this guy was last summer, just a year ago, presented on a Saturday, with 2 to 3 days, just didn't feel well. Clammy, no rash. The doctor it was from one of the walk-in clinics here on the East End. Suspected tick-borne disease, tested. He said what I say and what you all say to your doctors, your patients. If you're not better, come back. We always say that. If you're not better, come back. So he wasn't better, so he came back on Sunday. Now there's a different doctor working, right, on Sunday. So both of them drew a blood test, one on Saturday, one on Sunday, exactly 24 hours apart. We got him on the lab. So why am I showing this case? Remember this. This is him one day, PCR positive, next day PCR negative. 1 dose of doxy, PCR negative, and he's seroconverting. He has a 3-fold increase in his IgM in 24 hours, illustrating the lessons I've just been hammering on. IgM Western blot negative, by the way, in this patient. So what do these patients have in common? This is an East End patient here, a 10-year-old girl with an EM rash, seen by a very experienced clinician here on the East End who's been in practice decades, knows EM. 55-year-old presents to his PCP. This is from my hometown in Plymouth, Massachusetts. Insidious fever, fatigue, hemolytic anemia. The doctor ordered a smear for parasites. It was negative. And this 39-year-old guy, like I was saying, anybody here could pull in the driveway next weekend when Southampton Hospital has blood drive, Red Cross blood drive today, and just pull in. So what are these three? These are all real patients. What do they all have in common? Now that we're leaving Lyme disease, they all have Babesia in their bloodstream. They all have Babesia in their bloodstream. So you're going to say, Babesia causes EM? No, Babesia does not cause EM. What's the answer to the first case? Co-infection. Exactly. So this is CDC data up top. This is IMUGEN data here. This is 1 year nationwide, 1,500. This is 3 summers in our lab, 2,100 patients showing the months that you get Babesia. There's no, we don't see it hardly ever in April. How do you diagnose, so let's get boring here. How do you diagnose Babesia? What's your general strategy? You can look for the pathogen or you can look for the immune response. Is the germ present? Do I have antibodies? That's true for all infections, right? How do you look for the organism? You can do smears, you can inoculate hamsters, you can do a lot of things. But in real life, you can do smears or you can do PCR. And you can do serologies. Don't worry about the methodology. We do all these things. Don't worry about it. Just trust that your lab knows how to do methodologies. We use different antigens. We use recombinant antigens on an enzyme-based test, but IFA performs better, so we still use IFA. Smear is crude. Smear requires about 1 out of 4,000 red cells to be infected before a pathologist or a tech can see it under a microscope. 1 in 5,000. There's a point where you stop after you look at thousands of cells and say, I haven't seen any. Usually it's 4,000 or 5,000 cells. 1 in 40 million cells are infected. All I need is 1 copy of DNA in the aliquot that's going into the amplifier, and I can have a positive. So it's about 5 orders of magnitude more sensitive. So less organisms, so it's much more powerful. You can dilute, and this has been done, we've done this, we're not the first to do this. You dilute a patient's serum, or blood rather, you dilute it tenfold, tenfold, tenfold until the pathologist says, I can't see it anymore. You can dilute it 5 more logs and still have a positive PCR. 10 to the 5th more dilutions, more dilute specimen, and still have a positive PCR. So it's that much more powerful than the naked eye. I've told you this already. We talked about this. I'm not going to talk about transfusion transmitted Babesia. We don't have enough time. How do you diagnose anaplasma? To be boring. and repetitive. You can look for the organism, or you can look for the antibodies. Now, anaplasma, thank God, is a blood-borne disease. It lives in what? What's the G stand for? Granulocytes. It lives in blood cells. So whole blood is a nice, perfect, ideal specimen, unlike Lyme, where you just have a very short window. So it's not hard to find in the blood. And I can tell you, we've done with a certain state, Department of Public Health, sent us serum from PCR positive anaplasma cases. And depending on the methodology, if we use the older generations of serology, 7% were positive serologically on the day they were sick and in the ERs. Even with more sophisticated serologies, multiple recombinant antigens, which we use today for anaplasma, we can't get more than 20% seropositivity in acute specimens. So serologies is a terrible choice in an acutely sick patient for anaplasma. But convalescent, it's great. So here's a real case from Connecticut. Patient was admitted on this date. The doctor, a hospitalist, said to the, I don't know what you call the people who sit behind the desk in hospitals anymore. We used to call them ward clerks. I don't know, what do you call them now? Unit managers. He said, please order an anaplasma test, because the patient had low platelets, high LFTs, fever, headaches, sick. Then he went home off shift, and she didn't know. She looked at the menu and she clicked serologies because she didn't know what the doctor really wanted. So the patient was seronegative. 2 weeks later, the patient's still sick. Look at the seroconversion, still untreated, still PCR positive. This was not done and not available to do because they sent serum, not whole blood. We need whole blood to do PCR. So we couldn't go back. If we have whole blood, we can go back and freeze it up. PCR is stable. Freeze thaw, freeze thaw, freeze thaw in the lab. It's very stable. Those experiments have all been done. In recent year, HGA is really common. So HME. So this slide I made for the New England audiences, not for here. We don't see this disease in New England. I can tell you 4 or 5 years ago, the Lone Star tick has slowly started to show its face in New England. It's in Massachusetts. Its density is so low, except on Prudence Island for some reason, that it does not carry HME. There's been no human case that's been acquired in anyone that hasn't been to Long Island or New Jersey or the southern states, in Massachusetts or Connecticut or Rhode Island. But the tick is there. So it's it has a unique geography compared with the Ixodes transmitted diseases. We think, if you look at the map, from the Hudson River, from the New York state line, from there, including Long Island, swinging south is where you should be looking for this disease. But from there north so far, we're not encouraging doctors to order this test until we start seeing it. So how do you diagnose HME? Same thing. You look for the organism, you look for the antibody response. How do you look for the organism? HME, the M stands for monocytes. It is a blood-borne disease, easy to find by PCR, and they're seronegative acutely. Miyamotoi, we don't have time to talk about the interesting history, was discovered in ticks as a germ in nature, not felt to be pathogenic. It was discovered in Japan. Dr. Miyamoto discovered it, was named after him. He wrote it down, cataloged it, him and his team sequenced it. They filed it away, closed the book, said it probably isn't a pathogen, until 2011. It's only 5 years ago. The first case in the world, on the whole planet, was discovered in Russia. And in 2012, we were on a team that discovered it in a patient from New Jersey. First case in North America. How do you diagnose miyamotoi? It's like HGA. Think of it like HGA. Patients look that way too. Low platelets, sometimes low white count, not the opposite, not high white count. Transaminases 2 or 3 times normal, sick, headache, some of them ER sick, some of them, a quarter of the patients we've seen have had CAT scans, spinal taps, been admitted. You get that, be that sick. Like the sicker of the HGA patients, you see, looks just like that. You diagnose it the same way. It's briefly bacteremic, and then it seroconverts. It's easy, really. This is the first case report, so these are on the slide deck if anybody wants to read about it. This is the second case report. Look at the title, Mimicking HGA. This fools clinicians. We have ID docs call and say, I know this patient has HGA. I know HGA. I'm from the East End. I see lots of HGA. This patient has HGA. Usually it's HGA. 10% of the time, it's miyamotoi. It's not for specialists that see patients on referral a month or two later. This is ER, urgent care, walk-in clinics. They see this. So this is a publication from our lab, by the way. That's our lab founder right there. These are some references, just if you want to read about it. So these are all the spirochetes. These are louse. This is out west. This is not in New England. This is bed bugs transmitted, not tick transmitted. So miyamotoi shares its genes with relapsing fever. It's like 99% homologous genes to these germs. But phenotypically, it looks like an ixodes, a tick-borne disease, even though its genes are over there. So it shares a lot of genes. Let's say it shares 90% of the genes with B. burgdorferi, but it's a distinct organism. And there are implications, which I'm not going to go into, for serologic testing. In terms of cross-reactivity, in terms of what primers we use that can identify both or just one species, it gets a little bit too technical. I can tell you that it's been fun doing this in the lab, and that's all you need to know. But there are cross-reactivities, and it depends on, does serologies cross-react? You have a patient with no rash, tick bite, fever, headache, transaminase is up a little, platelets of 80,000. IgM for Lyme is really high. Does that patient have Lyme or miyamotoi? Well, it depends on how the Lyme test was done. If the whole cell sonicate was in the well, there's intense cross-reactivity because it shares 90% of the proteins and genes. If recombinant antigens were in the well, they're species-specific. But you don't have to worry about that. Just, it's been an interesting story. So relatively frequency data, we don't have to talk about this. It is worth knowing that about 2/3 of patients that are whole blood PCR positive for Lyme are seronegative. They are true window period infections. And this is in real life. We have no control over when patients choose to go to the doctors. Some people are stoic, stay home, are sick a week before they show up. Some people come in the first time they have a fever or headache. Hours later, they're in your office. How long have you been sick? Sick for 5 hours. So some people, are anxious, they're trigger happy to go to the doctor. Some people aren't. So I can tell you that just based on random test ordering and patient presentation, about 2/3 of the patient with Lyme in their blood are seronegative, and about 1/3 are seropositive. That tells me, so we diagnose about 200, our lab diagnoses about 200 cases of acute Lyme every year in the window period. So by adding PCR and 2,000 by serologies. So we improve the sensitivity of early Lyme about 10%. We can identify 10% more cases by looking at PCR. And it's the only way to diagnose miyamotoi. And we use the same primers, by the way. We use a Borrelia species primer. I'm just not going to go there. Yeah, this is important. This is a quote from the New England Journal of Medicine. Since serologic testing is unreliable early during the course of infection, the test of choice for anaplasma or miyamotoi is PCR. This is the pathologist at the Mass General in the CPC case discussion of miyamotoi, emphasizing what I've been trying to tell you all hour long. Why look for co-infections? They're common, and you can't always tell what a patient has. If they have Bell's palsy or a rash, you're lucky. You know that Lyme is part of the equation. We're actually in the process of counting 2016 data now. We're going to wait till November 1st, figuring that's probably the season end, except for some late cases of Lyme. We will look at our co-infection data soon, next month. We didn't have time to do it in real time all summer long this year. We didn't have enough manpower to keep looking at it. But in 2010 and 11, we combined 2 years. I'm sorry, this is all Massachusetts data. This is 4 hospitals in Massachusetts: Plymouth, Wareham, Falmouth, and Hyannis. I can't remember if Nantucket was on it. 4 or 5 hospitals in what the mass epicenter is. Of all Babesia cases, depending on the month and the zip code and all that, 10 to 25% of patients that were PCR positive for Babesia were co-infected with Lyme, and the other way around, and there are other permutations of co-infections. To the point, So our acute tick panel is very, DNA detection means PCR, is very weighted towards PCR. But it throws in Lyme serologies because that window period makes it, Lyme is not bloodborne. If you skip serologies, you'd miss a lot. So this is the test you guys order here. This is the older version of the test you order, up until 3 years ago. And here's what we call externally on most EMRs and computer test ordering sheets now, this says acute tick panel. Internally, this is the name we give it, but it has Lyme serologies with no IgG Western blot, and it has PCRs for everything else. And it has a Borrelia genus-wide primer that will be positive in either miyamotoi. If it's negative, there's no Borrelia in the blood. If it's positive, we have to, on the next test run, speciate it with species-specific primers. So it takes one more test run to get an answer if it's positive. So that's what our acute tick panel for Long Island is. For Massachusetts, it's similar to this, but it does not have HME on it. So that's our acute tick panel. I don't know what other labs do, but that's ours. And treatment, so the question comes up, I'm not talking obviously about treatment because you have the reference for that now, but the question comes up, I think, if a patient has EM, like the 10-year-old case, I said, as we left Lyme and started talking about Babesia, if a patient has absolutely classic EM, is any blood test necessary? And it's an item of debate and practice style. You may have one style, I may have a different style. Everybody's justified in what we do, really. You think it through. You say, I want to do a test. You say, I want to do an acute panel. If you want the cheapest way to do it, I have a very cost-conscious colleague of mine on Nantucket. She's the chief of staff out there, hospital employed, great doctor, smart, always wants to do the right thing, but doesn't want to waste money on tests. If she has a patient with EM, she orders one blood test. What do you think she orders? A Babesia PCR. It's the only test she orders. Everything else gets cured by doxy. She gives the patient doxy if it's an adult and orders a Babesia PCR. Now she knows that she won't miss Babesia and everything else is covered. She said this is the cheapest way. If you are the type of doctor that wants to know what the patient has, you want a diagnosis, I would do an acute tick panel in a patient like that. Yes?
What's the natural course of Babesia in a healthy 10-year-old child who has a spleen?
Yeah, that's a good question. The question was, what's the natural course of Babesia in a healthy kid? And I think everybody knows it. You can do serosurveys out here. It's been done on Shelter Island, on Nantucket, and you can find hundreds of patients that unequivocally have had Babesia serologically and don't even know it, and you get over it.
Then why test for it? Then why test for it?
So you could say, why test for it? I think you should test for it because there are subclinical cases. Patients don't come to the doctors when they're well and healthy. They come with a symptom usually. And I'm not making that assumption in the lab. Our specimens that come from urgent care centers and ERs, there's a reason for the patient to be there. So they're sick if the test is being ordered. I'm making that assumption. And in fact, I'm not in your shoes. I'm receiving the bloods that you decide to order or not order. And I have met doctors. I have a doctor colleague in Plymouth whose kid had Babesia and he elected. By the time he ordered the test and it came back, the kid was fine. He elected not to treat the kid and did a follow-up Babesia PCR a month later. It was gone, and that's how he did it. I don't even know if he did it in a follow-up PCR or did a CBC. That would be enough if the kid's not hemolyzing. The story is different for adults. The story is different for people who've had a splenectomy, who are on dialysis, who have had lymphoma survivors, who are on prednisone. Anybody who's this much immunosuppressed, you worry. The more immunosuppressed they are, the more you worry about Babesia. People die from Babesia. The other reason to test for it is we are supposed to, this is, by the way, FDA mandate to doctors. We're supposed to counsel our patients that they're excluded from being blood donors lifelong once they've been diagnosed with Babesia. I don't do that, but it's in the Federal Register that we're supposed to do that. That will go away soon. You're not parasitemic for life. That regulation was written in an era when nobody knew as much about Babesia, how long you were parasitemic, how much like malaria is it? Can you have late relapses a year or 2 or 3 later? So they played the most cautious card they could play at the time and said if you have Babesia, the proven Babesia infection, you can never be a blood donor until further notice. Now when the blood supply is going to be screened starting next year for Babesia, that regulation the sun will set on that regulation. But today we're supposed to tell patients not to be blood donors. So I don't know, I'm not going to argue we'll have different styles. What you do for your patients is the right thing, and what I do for my patients, it might not be the same for every patient. Some patients I will elect to treat, some patients I don't order follow-up tests on. High school athletes that are fine and are just fine, they don't come back anyhow for their blood tests.
Yeah, on the TBD4, is there a Lyme PCR on that?
Yes, we call it a Borrelia PCR.
Okay.
And the small print there identifies both Lyme and
But
miyamotoi.
on this side, I mean, on the,
No, it didn't used to. This was the older generation acute tick panel. You don't order this anymore.
okay.
With the emergence of miyamotoi and PCR for Lyme, this morphed into this. So this is yesterday's version. This is today's version, starting when, Bonnie? Like 3 summers ago. This is what you guys have been ordering. Up until 2013, this is what you got. And the reason for that is we didn't have good Borrelia primers then. We didn't know about miyamotoi. When that happened, this morphed into this. So this is your current, I should change the slide to make that clearer. This is yesterday's version. This is the current version. I think it was 2013 that it started.
Okay, I have a question. Yeah, you mentioned that you're not doing the Western blot on the TBD4 and
Right.
the Lyme, but if the Lyme is positive, you still don't do the Western blot or something?
I recommend not doing it. We will do anything you want, and our customers have different, we will create anything you want. We can reflex it. We can reflex it to positive. Some of our clients want it reflexed, some don't. The reason is the acute panels are not meant to answer the question that you have. Does my patient have Lyme arthritis? If you have a specific question, order a specific text. This is meant for the people who just come in and say, I've been sick for the past few days on the East End in the summer. It's meant for that patient. If you're looking at a different question, a late neurologic thing, so these other pathogens don't cause late neurologic things or arthritis. Nothing on this list causes arthritis except B-Burgdorferi. So rheumatologists tend to order mostly Lyme on a patient who has months of symptoms. I don't order this acute tick panel. I will just order a Lyme antibody serologic panel, which includes the Western blots. But as part of the acute panel, to save costs and resources, it's never positive. We looked at 250 patients, this is an 08, that had EM. None of them had, at the time, at their index specimen, there was 0 out of 250 that had positive IgG Western blots. They all did a month later or 2 months later, but they didn't acutely, so we don't include it on the acute tick panel. But if your question is, does this patient have Lyme, then both Western blot and enzyme-based testing is useful. One of the things that we offer, I'm not making this a commercial, I don't get paid by your business or commissioned, is that you can call and talk to me or Victor in the lab. That's one of my jobs, is anybody in this audience has a question, a follow-up test showed this, patient was treated, wasn't treated, co-infections, or serial tests, or could this be a reinfection? We take those calls all summer long, all year round, but especially in the summer. So you can call IMUGEN and get routed to me or Victor, who is the founder of the lab and very experienced, has been doing this for 30 years. And I like, I'm not bragging, I like what I can offer you because I see patients. I use these tests on Nantucket and Cape Cod, like you use them out here. So I'm still seeing patients.
And by the way, I've gotten those calls with you guys, and thank you so much, always very helpful.
Thank you.
Appreciate it. Summertime, July, kids got fever, stiff neck. Is it enterovirus? Is it Lyme? I need to know, what's the turnaround time for the PCR? Do you get the PCR and spinal fluid? Is that useful?
Yes, it's useful early. It's not useful, so is PCR spinal fluid useful? It's not useful in late encephalopathy. not there.
July fever.
Right,
headaches,
but
different.
acutely, when it could be Lyme meningitis, if you're going to put a needle in someone's spinal canal, I recommend sending paired serum serology for the antibody levels. And I'm not going to go into the details, but the way we do our capture assay does correct for total protein and total immunoglobulin by class, because it's different in the serum and CSF, so that's all corrected for. And if a patient has cells and it's caused by Lyme, PCR has a good chance of being positive. The yield is never as good as joint fluid. It's not as good, but I would
Which
do
is
it.
more likely to be positive for the blood or the spinal fluid for the PCR?
Both.
Both.
Yeah. So one more, I would implore you and beg you too, if you have patients that look sick, you've done a spinal tap, all the tests come back negative, then you test them again a week later, and we can't find any tick-borne disease, please call and tell me about that patient. So we can look for Powassan virus, deer tick virus, and other pathogens. We have a pathogen discovery R&D operation, which led to the miyamotoi story. And we would love to know if deer tick virus and Powassan virus are out here, for example. I know they're in the ticks. I don't know if they're transmitted to humans. I don't know. I know Powassan. There was an outbreak in New York. It was published on the CDC website last year. There was 22 cases, I think, in one small geographic region. And they were sick, hospitalized sick, don't recover fully, like St. Louis encephalitis sick. But deer tick virus, which is a different strain, they're very related, probably has a wide spectrum, subclinical, little sick people. They probably is out there, and we don't know it yet. We do have tests for these. We do have primers. We do have serologies. They're in a research level grade right now. And they're not on our website or on our menu, but if you call and say something's wrong with this patient and all your other tests are negative, we find things by looking, and those are the patients we want to know about. We'd love to look at weird cases that get sick, and something's going on, obviously.
I have a couple other. ECM, healthy kid, no fever, only there for a couple of days. Will you find anything in a PCR in the blood?
So yes, you will. If and it's been published. Wormser claims 50. If you get 20 ml of blood, the yield for a blood culture is about 50%. It's the same for PCR, which we use just a few microliters on.
The IgA in the blood, is it helpful for diagnosing neurologic infection?
Yeah. It means that the disease is early. It means recent. It's highly unusual. It's not impossible. It's highly unusual for it to be like IgM and persistent. There have been a few reported cases where people look apparently cured and have residual IgA, but that's 1 in a million. So IgA means recent. There are some people who IgA comes before IgM. There are about 1% of us that don't make IgM, so it improves the sensitivity.
They're not specific for CNS involvement?
No.
Okay.
And 2 isotypes is very, very sensitive. IgM can be mono and other things on a low level. An IgM of 1 and an IgA of 1, it's Lyme.
Okay. The reinfection, so if you have a kid who definitely had Lyme arthritis, years go by, can they actually get it again, and how would you diagnose that?
Yes, they can. You can get reinfected. It's believed, and Dr. Steer still believes, that after Lyme arthritis, just like after shingles, you're temporarily immune. You have enough antibodies. In Lyme, our antibodies are very helpful in a diagnostic sense. We can do Western blots, we can see them by all these methodologies. It's fun to look at, but they're not of a magnitude enough to be protective. So think of your Lyme antibodies as being diagnostically very helpful, not that protective. But after Lyme arthritis, you have so many antibodies, you're at least temporarily protected. But after a few years, you're not protected anymore.
So how would you diagnose it?
They can be diagnosed again, because only if you have archived samples from the first time. You can compare on the same test run, you can re-look at patients. Are there new bands on Western blotting? Is there a rising titer? You don't always get IgM the second time. An animistic immune response can bypass IgM. It can be just G and A, by the way. But we have a lot of experience in cases of reinfection. And we used to archive our blood and serum forever. Now we only archive it we archive it all for at least 5 years. But how much longer than 5 years depends on our freezer space. We guarantee to keep all our samples for 5 years. So if you send us a specimen today, and we have an old, whether you ask for it or not, we will thaw out the old specimen and put it on the same test run. And it helps us tease out reinfection.
Do you report out CDC non-specific bands?
We report every band we see. Yep.
So you
20 bands, 30 bands, 40 bands, not just the 10.
You
There's a lot of other information on the Western blot.
right.
Right.
And what are your what's your top 2 or 3 list of those?
The same as the CDC's, yeah. Yeah, 31, 34, 23,
Well,
and some of the higher molecular weight ones. You don't have to worry about what we're talking about. The individual bands sort of mean something to us. I would just, if I was in your shoes, I would just go to the interpretation, like I do when I get X-ray reports. Just read the final conclusion.
I have another question. What's your take on Starry?
So Starry, yeah, is in, I don't know if it's in Long Island.
It is.
I know that it's mysterious in terms of the pathogen characteristic. It's amblyoma transmitted. There is a rash associated with Starry. We're at the beginning of the learning curve as to its epidemiology right now.
What about testing?
Yeah, you can test for Starry. Yeah. We can test for miyamotoi, the recently described Borrelia up in the upper Midwest. We can test for these. Before we bring something to prime time, we'd like to be convinced it's out there. We don't want to just push tests on you and say, now we order this, throw this in your panel, throw this in your panel, unless it's out there. We'd love to survey and look with you.
We had a case where an 11-year-old boy came in and he had 2 rashes on his back, and he came into my lab.
Right.
And with his mother, and he had 2 Lyme-like rashes on his back.
Right.
Very convincing. And his mother said, well, I pulled this tick off of this rash this morning, and it was an amblyoma tick.
Right.
And
So, I mean, I would,
Starry.
yeah, that could be a case of Starry for sure. But I still would like our own kids that come in with a tick, you pull it off, even if I know it hasn't been on 24 hours, if they get a fever in the summer out here, I'm going to run an acute tick panel because, and that's why I don't recommend testing ticks for pathogens directly all the time, is because it's the bullet that you don't hear that gets you. And people with Lyme arthritis never recall a tick bite, never. Because if they did, they would have been treated with doxy a year ago and wouldn't have Lyme arthritis. The reason we treat Lyme disease is to prevent late sequelae. And what about the tick that's on you that you don't see? I would assume everybody out here, kids, toddlers up, are at risk. And if they have one tick on them, they could have another tick on them. You don't just find one ant in your house, right?
Another question, what do you do if somebody else orders an antibody panel on an asymptomatic person, it comes up positive, what do you recommend to them?
So that's, so what do you do when a test maybe shouldn't have been ordered, but it's ordered, and something is positive on that test? I know what I do. I react differently if it's PCR. If a patient is bacteremic, I would react like a positive blood culture. In fact, I have a gripe, your lab people. I don't know how to solve this, but I think a positive PCR for some of these agents should be treated like a panic value by a lab. It should be communicated on an urgent basis to the doctor. The same way you handle E. coli positive blood cultures, I think you should handle, because you, as a lab person, and I'm further removed than you, if you send me, I don't know how sick this patient is. In fact, if you send me a blood test, I don't know if it's from somebody in the ICU or somebody who went to work this morning, feeling not that bad. But what if it's somebody that's sick? I mean, I would treat it, you don't know that, I don't know that. I think the doctor should be aware of a positive germ in a patient's bloodstream. And let him decide, him or her decide how to react to it. So, but if it's a serology, then that's a different. Then I walk, I don't run. And I have the patient back for history and physical. And if it's just IgM, you know, the CDC says IgM, and everybody agrees with this, the American College of Rheumatology. Low levels of IgM only as the sole serologic finding in a patient with more than 4 to 6 weeks of symptoms is a negative blood test. Patients don't know that.
So a significantly positive IgG Western blot, no history of Lyme, not been treated for it, nothing
And
considered.
so now she's cornering me.
Those
What
are
if
the ones
it's-
we get stuck
I
with.
know, because in Massachusetts, the crew that, what do you call it? The high tension lines on the side of the road, they prune trees, so in the winter storms, you don't lose your power. So the people that are out there doing that are an occupational risk for tick-borne diseases. And in Massachusetts, the companies, the tree companies that are outsourced by the power companies that do that, as part of their job, they get tick-borne Lyme tests every year. And we have patients who are negative for a few years, and then they're incredibly positive. And you call them in, and they're totally asymptomatic. So I always tell my residents and fellows, we don't treat blood tests, we treat patients. But sometimes I'm convinced there's a dormant spirochete that's been untreated in this patient. What would you do if it was a positive VDRL? The patient deserves the assumption that there's a likelihood that they're going to hear from that someday, and the likelihood is higher in adults. In kids are more likely to get exposed to Lyme and have no late sequelae. Adults are less likely to. It happens, but adults are more at risk to get late sequelae, neurologic, cardiac, arthritis. And I think there are people out in this community that are throwing antibiotics around for a lot less reasons. So I treat those patients with 1 course of antibiotics.
Of course, being how long?
I treat them, she's really pinning me down.
I am.
Of course, I treat them with 28 days of oral antibiotics, as if they have a late potential hidden spirochete in their synovium or in their conduction system or brain. I treat them that way. I do. I don't want to say this in public, that I treat blood tests and not patients. And that patient doesn't have Lyme disease. That patient has a positive blood test and is asymptomatic. A convincing blood test of exposure, but we do that with latent TB testing, don't we? We have patients we know have been exposed and have no symptoms, and we treat them.
And what is the turnaround time for the PCR for the Lyme?
You said that. It depends, sorry, I forgot. It depends on when we get your specimen. I can tell you that if we get it anytime overnight before 10 a.m., we report it by 4 p.m. that same day.
Do you run it daily? Do you run it daily?
Well, yeah, we run it daily, not Sundays. And in the winter, we do it 5 days. In the summer, we do 6 days. And we run them all, and if we have to re-extract and repeat and retest, it's all done the same day. And we have electronic interfaces with our busiest customers, like Southampton Hospital and Sunrise and stuff. So we will report out electronically. And real time, by the way, means in the middle of the test run, let's say we have 96 specimens going through the PCR machine. What if well number 50 is positive in the first half hour of the test run? We don't have to wait till the whole test run to report that well. All right, if it's a robust CT number and early, it gets reported before the test run is done. Even it gets reported. That's one of the things real time means. So we report it, and the problem is going to be there are 2 problems. The first is how long does it take us to get the specimen, and the second problem is some of our clients in panel testing don't want preliminary reports because IT departments don't like it, interfaces don't like it, and that is a problem for us. I may know that you have Babesia PCR positive, but there may be something funky about the Lyme test that's being repeated tomorrow. So I'm holding on to a known positive until the whole acute tick panel is done because your IT people don't want preliminary reports. That is the second problem. So the first problem is transporting the stuff to us, which is FedEx or courier. We get them overnight usually. We have people who come in at 3 in the morning to start processing specimens, because we get about 1,000 blood donors every day overnight. You donate blood today, overnight, comes in. We have people come in at 3 in the morning to start processing both clinical specimens and blood donor specimens. And they get on that day's test run and reported before people go home the same day. Always. As long as we're not waiting. I don't know how to do that. I don't know how to handle that, because I've called IT people in hospitals and say, look, this, and they say, we don't want preliminary or partial reports.
Call us, Stan, call us.
You know,
I just had a question, the PCR, is that considered confirmatory for insurance companies? Because a lot of people say, I need a positive Western blot. Is
no,
the
it's not
PCR
confirmatory.
But do they treat, do insurance
That I don't
companies?
know. I'm not an expert on that corner of it. Sort of question has to do with insurance authorization, this, that. And I know that different payers, like one we started with last year, Bonnie, have different rules, and if sales through, and there are some rules by different payers that make no sense and all this stuff.
I have a question about a total IgG count in serology. I just wonder why, I know that there are norms, but would it be that cost prohibitive to say do a total IgG count and then use a ratio as a threshold? So say you have like a child with common variable immunodeficiency who's starting out with a 500
Right,
IgG count
yes.
at the beginning.
We do that automatically.
You do it.
We do it automatically.
Does everyone do that?
No,
Okay.
no,
Good to know.
no. Our test, more than you want to know, our antibody-capture enzyme-based ELISA type test answers this question. Of all of your IgG that you have, what percentage of that is specifically directed to Bieber growth factor? Independent of your total protein and total IgG even. What percentage of it, which makes it ideally suited for comparing two body compartments, CSF and serum, for example. So we do that, but that's part of the antibody capture methodology, which is not automatable, labor intensive, and not done by many people that I know of. It's public, it's been published, anybody can do it, we don't own any patents on it. The reason a lot of labs don't do it is it's not automatable. It's kind of tedious. It takes 6 hours to do that. And there are five incubations, probably, 6 incubations, a lot of incubations. Each one wash. It's very time consuming for people who have been around. But it's very accurate.
Sounds expensive.
Yeah. We can do it more cost effectively because we're set up to do large volumes of it. That's all we do, is vector-borne diseases. We don't do stuff that's easy.
At what stage is that antibody capture that you do? Like,
Positive?
yeah.
Well, we have old data showing at the time of EM about 80% were positive. By the time you have multiple EM, it's not, the number's higher. And as you go out in time, it goes higher and higher and higher. Yeah. Yeah. I think the combination of antibody capture, EIAs we call them, and a whole blood PCR is the best test today for early acute Lyme. And if it's negative and you still suspect it, wait a week and redo it. Treated or untreated.
What about, say, in maybe a child who has, again, common variable immunodeficiency and possibly didn't meet the threshold at the time but is still experiencing symptoms? What kind of
Well, PCR would be a great test for that. If the germ is there. So she's asking a very specific question about immune deficient kids. The same holds true as in adults. If you guys treat adults, patients who are lymphoma survivors with splenectomies and now are on Rituxan don't make normal immune responses. And we look for the germ more often in such patients. It's a type of thing that deserves a phone call from me or Victor in the lab. This is my patient. That's not the average patient you're going to see. All right, I'm going to hang up here. Thank you for staying past the hour.